Vanakkam. If the flexors of the hand are important, the extensors are equally important, if not more. And to understand the management of any problem on the extensor, we need to start with understanding the anatomy. And by anatomy, I don't mean just the origin, the insertion, the innervation and the action, but more importantly, the functional anatomy and the surgical anatomy, which is most important for practical purposes. By functional anatomy, I mean the length of the fibers, the actual mechanism of action and how it is so efficient. And by surgical anatomy, I mean when you are transferring the tendon or when the muscle is paralyzed, how is it replaced and what is the angle in which the donor tendon must be brought to achieve good function. The extensor expansion in the finger will be dealt with in a later video. In this video, we shall be learning about the anatomy of the extrinsic extensor muscles, that is, the extensor muscles that act on the hand, fingers and wrist. So, we shall not be considering muscles like the anconeus, supinator and brachioradialis, and we shall be dealing with the structural, functional and surgical anatomy. First, we shall see a short introduction about the muscles, then learn about each individual muscle, the structural details, that is, the origin, the crossing at the wrist, the insertion, the nerve supply and the action, then the functional significance of each muscle like the fiber length, the excursion, the balance of forces and the functional significance of the action of the muscle, the surgical significance, that is the surgical anatomy, the use of the particular muscle as a transfer and how to replace the muscle if lost or paralyzed. And we shall end with the study of the Juncturae tendinae, that is the interconnections that occur before the extensor expansion forms. The details about the extensor expansion will be dealt with later in the next video. When we consider the extrinsic extensor muscles acting on the hand, we will be dealing with 9 muscles. These muscles present on the extensor aspect of the forearm can be divided into the superficial and deep layers. The superficial group consists of 5 muscles: the extensor carpi radialis longus, the ECRL, the extensor carpi radialis brevis, the ECRB, the extensor digitorum communis, the EDC, the extensor digitae minimi, the EDM and the extensor carpi ulnaris, the ECU. And the deep group consists of 4 muscles: the abductor pollicis longus, the APL, the extensor pollicis brevis, the EPB, the extensor pollicis longus, the EPL and the extensor indicis proprius, the EIP. And generally speaking, all these muscles are innervated by the motor branches from the radial nerve, either directly from the radial nerve or from the motor division of the radial nerve on the extensor aspect of the forearm known as the posterior interosseous nerve. And when these tendons reach the dorsal aspect of the wrist, they pass through 6 well delimited compartments, and on the dorsum of the hand, various intertendinous connections, the Juncturae tendinae, are seen. Now we shall begin a study of the individual muscles. First, the superficial muscles, and we shall consider the extensor carpi radialis longus, which we shall be referring to as the ECRL. This muscle originates from the lateral supracondylar ridge of the humerus, from the lateral intermuscular septum and by a few fibers from the lateral epicondyle of the humerus. So, it has got an extensive origin from the very lower end of the lateral aspect of the humerus. The muscle runs along the lateral border of the radius, then beneath the abductor pollicis longus and extensor pollicis brevis tendons, and then crosses the wrist through the second dorsal extensor compartment on the radial side of the Lister's tubercle on the radius along with the extensor carpi radialis brevis tendon. It is then inserted on the dorsal surface of the base of the second metacarpal bone more on its radial side. The nerve supply of this muscle is directly from the motor branches from the radial nerve. When this muscle contracts, it causes extension of the wrist joint and also radial abduction of the hand at the level of the wrist. The muscle fiber length is variable as the muscle arises from the lower end of the humerus, and the unique feature of this muscle when it acts on the wrist is it not only causes extension of the wrist, but it also tends to move the hand towards the thumb. That is, when the extension occurs, the thumb automatically moves towards the fingers, and when there is a radial abduction, this effect is even more accentuated. The tendon, when it is contracting, can be identified by the prominence on the radial aspect of the extensors of the fingers. This muscle can be used for tendon transfer in ulnar nerve palsy because it has a long tendon, and the wrist extension will not be affected by removing this muscle, as the wrist extension is maintained by the extensor carpi radialis brevis and the radial deviation is maintained by the abductor pollicis longus. And when this muscle is either paralyzed or lost, another muscle needs to be transferred to do this extension, and in that situation it is not ideal to insert it into the extensor carpi radialis longus because of the radial deviation action. The extensor carpi radialis brevis, or the ECRB. This muscle has its origin from the lateral epicondyle of the humerus by the common extensor tendon. This muscle is closely connected with that of the extensor carpi radialis longus, and just like the ECRL, it also passes beneath the abductor pollicis longus and extensor pollicis brevis tendons. It crosses the wrist along with the extensor carpi radialis longus tendon in the second dorsal compartment. It is inserted on the lateral or radial dorsal surface on the base of the third metacarpal bone. As we know, the third metacarpal bone is almost like the central beam of the hand. This muscle usually receives its nerve supply from the posterior interosseous nerve, which is the motor division of the radial nerve. This muscle, when it acts, it causes extension of the wrist, and it has a central axis of pull, which is different from the action of the extensor carpi radialis longus, which has more of a radial deviation. Though the ECRB is smaller in mass than the ECRL, it is more effective as a wrist extensor because it has a larger tension fraction than the ECRL, it has a larger moment for extension and a smaller moment for radial abduction. It can be palpated just ulnar to the palpated ECRL tendon at the level of the dorsum of the wrist. In case of paralysis of the wrist extensors, a muscle needs to be transferred to the ECRB. Here, we need to maintain the direction of pull. As shown in the example, the pronator teres, if it is used for transfer, it should be attached to the intact ECRB tendon and not divided tendon. Though the extensor carpi radialis brevis is so important, it can be used as a transfer either for the EE4T procedure or to replace the adductor of the thumb. Whatever be the transfer it is used for, basic principles must be followed to maintain the extension of the wrist by the ECRB. Hence, this tendon must stay within the retinaculum, must stay on the dorsum of the hand, and must provide an action synergistic with wrist extension. The extensor digitorum communis, or the EDC, is also a superficial muscle on the extensor aspect which has its origin from the lateral epicondyle of the humerus via the common extensor tendon, and it also arises from the covering fascia and the intermuscular septa at its sides. In the lower part of the forearm, the muscle forms 4 tendons, and these tendons pass deep to the extensor retinaculum through the 4th compartment. On the dorsum of the hand, the tendons then diverge towards the 4 digits. Each tendon helps to form an aponeurosis over the dorsum of the hand, which is known as the dorsal digital expansion or extensor hood, which will be discussed in detail in the next video. The muscle is innervated by a branch from the posterior interosseous nerve with the root value of C7 and sometimes C8. The primary action of the extensor digitorum communis is extension of the metacarpophalangeal joints only. It also helps to extend both the interphalangeal joints, but this is mediated predominantly by the dorsal and palmar interossei and lumbricals of the hand. This EDC is not a very strong muscle. In fact, the FDS and FDP of the middle finger alone are together stronger than all the extensors to the fingers, and the EDC to the fingers, though there is a common muscle, they are distinct to the four fingers. The EDC muscle portion to the index is a long thin muscle with a flattened tendon. The part of the muscle supplying the ring finger has more distal muscle fibers, a flat tendon with connections to the middle and ring fingers, and the EDC to the little finger is difficult to separate the muscle from the muscle to the ring finger, and sometimes the tendon to the little finger itself is a branch from the ring tendon. Surgically, it is important to transfer a tendon to the extensor digitorum communis in radial nerve palsy to achieve extension of the fingers. This can be done with the extensor digitorum communis tendons intact, that is, an end to side suturing of the transferred tendon, or after dividing the EDC tendons, where an end-to-end suturing of the tendons can be done. If done with the EDC tendons intact, the tendons must lie in their extensor retinaculum compartment. If it is done after dividing the extensor tendons, the tendons must be moved to the subcutaneous plane so that the line of pull is straight. The extensor digitorum minimi muscle also arises from the common extensor tendon by a thin tendinous slip. This muscle lies radial to the extensor carpi ulnaris muscle, and the tendon passes through a compartment on the extensor retinaculum posterior to the distal radiulnar joint. This is the fifth dorsal extensor compartment. It then divides into two thin tendons as it crosses the dorsum of the hand and finally joins the extensor digitorum tendon to the little finger. Along with the EDC to the little finger, these three tendons attach to the dorsal digital expansion of the fifth digit, that is the little finger. The innervation to the EDM is a branch from the posterior interosseous nerve with the root value of C7, 8. The extensor digiti minimi is a two-joint muscle. It acts as an extensor of both the wrist joint, where it has a very weak action, but it mainly extends the little finger at the metacarpophalangeal joint. We have already seen that the EDM consists of two thin tendons. It provides individual extension at the metacarpophalangeal joint of the little finger. But it is important to remember that this muscle is sometimes the main extensor of the little finger, because usually there is a very variable contribution from the EDC to the little finger. So in any situation, if the extensor digiti minimi is removed for a tendon transfer, the EDC of the little finger may not be able to extend the little finger. Then we will need to transfer a slip from the EDC of the ring finger to the little finger in such cases. This happens especially in cases where the EDC to the little finger looks more like a junctura than a tendon. The extensor carpi ulnaris, or the ECU, also originates from the lateral epicondyle of the humerus and also a small portion on the posterior border of the ulna. It is the first muscle on the extensor aspect of the forearm when palpated from the ulna. It crosses the wrist through the sixth dorsal compartment, and it is inserted on the base of the fifth metacarpal. It is innervated by a branch from the posterior interosseous nerve with a root value of C7, C8. The extensor carpi ulnaris extends the wrist, but when acting alone, it inclines the hand towards the ulnar side. The ECU is a long muscle with short fibers. The tendon is 21 centimeters long, but the fiber length is only 4 centimeters. So, there is a limited excursion of about 3.5 centimeters for the extensor carpi ulnaris. The ECU can be used as a transfer for providing abduction pronation of the thumb, as a motor for digital flexors, but it should not be used in rheumatoid arthritis because it is needed as a stabilizer of the distal radioulnar joint. Now we shall discuss the deep muscles, and we shall begin with the abductor pollicis longus, which will be referred to as the APL. All the four deep extensor muscles to the hand originate from the radius, interosseous membrane and ulna. The APL has the most proximal origin of these four muscles, and it originates from the lateral part of the dorsal surface of the body of ulna, below the insertion of the anconeus, from the interosseous membrane and from the middle third of the dorsal surface of the body of the radius. The muscle passes obliquely downward and lateralward and ends in a tendon that runs through a groove on the lateral side of the lower end of the radius in the first dorsal compartment of the wrist, and in this compartment it is accompanied by the EPB tendon. The insertion of the APL muscle is interesting. It is inserted by two parts, the distal superficial part and the proximal deep part. The superficial part is inserted by one or more tendons into the radial side of the base of the first metacarpal bone, and the deep part is inserted variably into the trapezium, the joint capsule and its ligaments. The muscle is innervated by a branch from the posterior interosseous nerve with a root value of C7, C8. The abductor pollicis longus is a multi-stranded tendon. It pulls the thumb laterally or radially, and it is important because it maintains the arch of the thumb against the powerful adductors. By its continued action, it helps to abduct the wrist, that is radial deviation, and also flex the wrist. It is important to understand that the APL insertion on the trapezium and the abductor pollicis brevis origin on the same bone is the only connection between the thumb's intrinsic and extrinsic muscles. As the thumb starts acting, these two muscles coordinate to keep the trapezium stable in the carpus, which is very important for the proper functioning of the thumb, both in precision and power grip. When there is a paralysis of the abductor pollicis longus, as in radial palsy, the flexor carpi radialis needs to be transferred, as we need a very strong muscle. But this can be done only if the flexor carpi ulnaris has not already been used. Also, the functioning APL can be transferred to replace the first dorsal interosseous muscle to restore key pinch in ulnar palsy. In conditions like CMC joint arthritis of the thumb, part of the APL tendon can be used in the reconstruction. The extensor pollicis brevis muscle, referred to as the EPB, also arises from the interosseous membrane and from the dorsal surface of the radius. Its direction is similar to that of the abductor pollicis longus, which lies proximal and to the radial side, and the tendon of the EPB also runs in the first dorsal compartment of the wrist along with the abductor pollicis longus tendon. The tendon is inserted on the base of the proximal phalanx of the thumb and innervated by a branch from the posterior interosseous nerve with a root value of C7, C8. The extensor pollicis brevis extends and abducts the thumb at the carpometacarpal and metacarpophalangeal joints. It is a weak muscle and can only be used for positioning the index finger in ulnar palsy, like for pianists or typists, but it is not good enough to replace the first dorsal interosseous muscle for pinch. The next deep muscle we shall be considering is the extensor pollicis longus, which will be referred to as the EPL. It originates from the lateral part of the middle third of the posterior surface of the ulna and the adjacent part of the interosseous membrane. It is present deep to the EDC muscle, and it crosses the wrist under the extensor retinaculum through the third compartment around the Lister's tubercle on the radius. It then gets inserted at the dorsal surface of the base of the terminal phalanx of the thumb. It is again innervated by a branch from the posterior interosseous nerve with the root value of C7 and C8, but here C8 predominates. The extensor pollicis longus acts primarily as an extensor of the interphalangeal joint of the thumb. At the level of the metacarpophalangeal joint, it is also an extensor and adductor, and at the level of the CMC joint, it is an adductor and extensor, and at the level of the wrist, it is an extensor and radial deviator. So if we draw a line from the radial side of the metacarpophalangeal joint of the thumb to the Lister's tubercle, we get the approximate position of the extensor pollicis longus. In ulnar palsy, both the FPL and the EPL alone stabilize the thumb, hence there is an adduction at the CMC joint. When there is a paralysis of the extensor pollicis longus, the palmaris longus can be used as a motor to reanimate it. But in situations where the EPL has ruptured and has to be reconstructed, the extensor indicis proprius is better as a transfer. The extensor indicis proprius, or the EIP, has the most distal origin among the 4 deep extensor muscles. It originates from the distal third of the dorsal part of the body of the ulna and the interosseous membrane. This muscle is deep to the extensor digitorum communis, and the tendon runs through the 4th tendon compartment together with the extensor digitorum, from where it projects into the dorsal aponeurosis of the index finger, and it is inserted opposite the head of the 2nd metacarpal bone, where it joins the ulnar side of the tendon of the EDC of the index finger. The EIP lacks juncturae tendinum. This muscle is also innervated by the branch from the posterior interosseous nerve with a root value of C7, C8, with C8 predominating. The extensor indicis extends the index finger and by its continued action assists in extending the wrist and the midcarpal joints. Due to the separate muscle, the EIP provides independent extension of the index finger, and we need to remember the additional tendon to this finger is on the ulnar side of the main EDC to the index. Removing the extensor indicis proprius will not cause a deficit because the EDC to the index finger can extend the index, but the defect in the hood must be well repaired. Due to its versatile action, the extensor indicis proprius can be used as a new motor for opponentsplasty in cases of median nerve palsy, for claw correction in cases of ulnar nerve palsy, and also to reconstruct a ruptured extensor pollicis longus. Before the extensor expansion forms on the dorsum of the fingers, an important structure that we come across are the Juncturae tendinae. The extensor tendons of the index, middle, ring and little fingers are interconnected by fibrous bands called Juncturae tendinae proximal to the metacarpophalangeal joints. There are 3 distinct types of Juncturae tendinae depending on the morphology. Type 1 is thin and filamentous with a shape either square, rhomboidal or triangular, and commonly seen between the extensors to the index and mid fingers. Type 2 Juncturae are more tendinous and thicker than type 1 and located a little more distally and commonly found between the middle and ring finger extensor tendons. And type 3 Juncturae are typically slips from the extensor digitorum communis. They are further divided into subtypes 3R and 3Y and commonly found between the ring and little finger extensor tendons. This pictorial representation shows the subtype 3R where it is oriented like the small letter R, and the subtype 3Y where it is oriented like the shape of the letter Y. These Juncturae tendinae have very specific functions. They link the motion between the extensor tendons, redistribute the forces occurring during fist formation, and they space the extensor digitorum communis tendons for maximum efficiency. They reduce the excessive load at the sagittal bands, and finally they stabilize the metacarpophalangeal joints.
Hi, I hope you liked the video. Remember, this is a series. Every first Sunday of the month you will have a lecture. Every second Sunday there will be a clinical case discussion, and every third Sunday a surgical procedure or surgical technique will be demonstrated. Every fourth Sunday there will be a new series called Tirukkural with GK, and every fifth Sunday, if it occurs, there will be a public information video. So subscribe to stay connected with the latest in learning and enjoying hand surgery.